All right, while we're finishing readjusting the stage, I'd like to invite the first three speakers for this session to come up to the stage so we can facilitate moving between the talks. And I'd like to encourage the remainder of you to, if you're a virtual attendee, please feel free to post some questions in the chat. And for those of you in the room, don't forget to rate some of these sessions and leave your comments as well using the AAHKS app. This is the beginning of session 5. My name is Greg Polkowski from Nashville, Tennessee. I'm joined with my good friend and esteemed colleague, Muibat Adilani from St. Louis, Missouri. We're going to be moderating session number 5, primary total knee arthroplasty. We're going to get started with paper number 27 by Alisina Shahi, who's going to be talking about how we can save lungs with knee replacement surgery.
Good afternoon, everyone. I would like to thank AAHKS for giving us the opportunity to present our work, and also a special thank to my co-authors. Our disclosures can be found at the Academy's website, none of which are pertinent to this talk. Total hip and knee arthroplasty are the ultimate treatment for degenerative joint disease. And based on the projection data, we'll be performing more and more of these procedures in the coming years. But we do believe that arthroplasty is more than that. It's more than just a treatment for DJD. It's a pivotal moment in patients' general health where they undergo multiple optimizations, as part of which they go through a process of smoke cessation. For that reason, we wanted to investigate the demographics of smoking status in patients who undergo total knee and total hip arthroplasty, and assess the number of patients who quit smoking for their arthroplasty procedure, explore their relapse rate, and also investigate the rate of PJI in these patients and see if smoking status plays a role in this. Therefore, we conducted a retrospective multi-center study spanning from year 2000 up until 2018. We captured patients' smoking status, and we followed the patients for 2 years. And we also identified patients who relapsed and went back to smoking. In addition to that, we captured demographic information, including gender, age, BMI, the procedure type, and Charlson and Elix-Hauser comorbidity indices. We categorized our cohort into 4 main groups. Group A were current smokers, Group B were former smokers, Group C were the patients who actually stopped smoking for their arthroplasty procedure, and Group D were non-smokers. All patients who were smoking were consulted for smoke cessation, and they were also referred to a multidisciplinary smoking cessation clinics. Bivariate analysis was done using Fisher's exact test, and we also created a multivariate regression model to determine the risk factor for infection. We enrolled more than 18,500 patients, and there were no difference in the demographics of the study groups. Looking at our cohort, we had 8.6% of our patients who were current smokers, 26% were former smokers, and this is the group that we want to focus on today. 21% actually stopped smoking for their arthroplasty procedure, and 43% were non-smokers of all time. Looking closer at this data, patients who were current smokers had statistically higher rates of infection compared to those who were non-smokers. Being a former smoker did not increase the chance of these patients to develop PJI. And of those who stopped smoking, only 35% had a relapse within 2 years of their arthroplasty procedure. And looking at these patients, the ones who had a relapse and went back to smoking actually had a statistically higher rates of developing PJI also. The rest of the risk factors based on our multivariate regression models was AIDS, liver disease, hypothyroidism, renal failure, RA, diabetes, and alcohol abuse. Our study had some limitations, and our findings should be interpreted in light of these shortcomings. This was a retrospective study with all its inherent limitations. The quantity of nicotine or the number of cigarettes that were smoked by these patients were not captured. Obviously, there's a variability with smoke cessation counseling that was not also investigated in this study. And as far as the complications, we looked at PJI as the only endpoint for complication, and PJI was defined by reoperation for PJI, and we all know that's an understatement. And if we included wound complications, cardiac or pulmonary complications, or mortality, we know that these complications would have probably been higher. And lastly, our follow-up period was only 2 years, and as the follow-up period continues, the rate of relapse may rise. Now, this is straight up out of the CDC website. We know that 60% of adults who are smoking really want to quit smoking. However, only less than 1 per 10 adults succeed every year to stop smoking, and that's alarming. And when you look at the successful smoke cessation guidelines, their success rate is anywhere from 5%, and the best thing out there is like 38%. And that's where it gets interesting. Our success rate for smoke cessation and having no relapse was almost 65%. And we do believe that arthroplasty, again, is more than that, and it's a life-changing event for these patients that not only improves their functionality, but also alerts them about their general health and gets their medical conditions under control. And that's why we think that arthroplasty can potentially even save their lungs. Thank you.